Hi, Jane here for part 3, and we were just discussing POLST. Here's what a POLST form usually includes, and remember, POLST is Practitioner's Order for Life-Sustaining Treatment. POLST form usually includes specific CPR and DNR instructions, specific degrees of treatment like IV fluids, intubation, and ventilator instructions, specific degrees of artificially administered nutrition, hydration, and use of antibiotics, comfort measures and palliative treatment. POLST specifies the participants in the POLST process, including medical personnel, and how the orders were determined. And POLST includes the name of the patient's guardian, surrogate, or healthcare proxy. You can see that POLST incorporates elements of both. Sorry about that. Little technical difficulties. Okay. Anyway, you can see that POLST incorporates elements of both the living will and the healthcare proxy. POLST forms typically provide a more detailed checklist than advance directives. POLST forms can also carry more weight than a living will or healthcare proxy. For instance, paramedics and EMTs are required to sustain life, but they will follow POLST because it is signed by a medical practitioner, which isn't true of the other forms of advance directives. And unlike the other advance directives, the medical signatory always has a copy of the POLST. Advance directives may or may not be given to a person's doctor, nurse, practitioner, or physician's assistant. Ideally, the patient has a living will, a healthcare proxy, and if their life expectancy is limited, a POLST as well. We talked about advanced care legal documents. Now let's take a moment to look a little more about what might be included in a living will or what might be discussed with a healthcare proxy. When a patient is dying and a cure is not believed possible, treatments covered could include CPR, ventilator use, artificial nutrition, hydration, and palliative care. Let's start with CPR and ventilator use. We all know that on TV it works most of the time. But as nurses, we also know that in real life, on healthy patients, it works only about 17% of the time. We also know that it doesn't just involve chest compressions, which, by the way, usually breaks the patient's ribs. CPR also includes medications and shocks that can help restart the heart, can also lead to intubation. It also often includes being put on a respirator. For CPR to work best, all these tactics might have to be deployed: chest compressions, medications, shocks, and intubation. And with the elderly, the older the person is, the more likely it is that the CPR will result in a broken rib or collapsed lung. Windpipe damage can result from use of a ventilator. People engaging in advanced care planning find these facts useful to know. Don't just depend on what you see on television. Individuals also need to consider under what circumstances artificial nutrition and hydration should be used. They should recognize that this can involve intubation, which can cause various degrees of discomfort if consciousness is regained. Individuals can specify that when the prognosis for life expectancy is short, there's a preference for quality of life for the remaining time, including the application of palliative care. Let's look at some real-life scenarios. If a stroke leaves the patient paralyzed or severely mentally impaired, would he or she want CPR? If dementia leaves the patient unable to recognize family, friends, oneself, surroundings, unable to feed him or herself, would this person want a feeding or hydration tube? If a terminally ill patient becomes unconscious and develops pneumonia, would he or she want to be on a ventilator? These are absolutely difficult decisions to make, which is why it's important to consider them in full cognitive consciousness. For some patients, there may also be financial considerations to take into account. Treatment might not be fully covered by insurance. The patient may wish to leave an estate. And let's face it, keeping a patient that's terminally ill alive can be very costly. So if the patient wants to leave an estate, the patient needs to consider that the cost of treatment can affect how much is left in the estate, and that being in a nursing home can affect how much is left in an estate. Therefore, advance directives can affect the assets left in an estate. Here are some legal considerations to be aware of. With PULST, as we said, a medical professional is the person who signs the order, and it is an order, unlike other types of advance directives, living wills, and healthcare proxies. In terms of signatories, with living wills and healthcare durable powers of attorney or healthcare proxies, the patient's signature must be witnessed and signed by 2 witnesses. The witnesses don't have to read the form, they only have to witness the signing. And in the case of the healthcare proxy, the witnesses cannot be the healthcare proxy or proxies themselves. While states have different standard forms, most have the same content, and out-of-state forms are recognized locally. Even forms from other countries can be recognized in the United States. For instance, vacationers from Philadelphia or even Quebec who become mentally incapacitated here in Cape May County will have their forms recognized by Cape May County. Remember, living wills and healthcare proxies are revocable, and they can be changed whenever one wishes to change them. The medical community supports the right of patients to be informed of and choose their treatment or non-treatment. The New Jersey Hospital Association currently has an initiative to increase the use of advance directives, especially PULST. CAPE Regional can assist patients in understanding the usefulness of having personalized advance directives. Advance directives help the medical community make timely decisions in a potentially rapidly changing medical event. Advance directives help them make decisions more rapidly and can reduce undertreatment or overtreatment of the patient. Without advance directives or PULST, what types of problems might occur with patients who become unconscious? The medical provider may perform CPR or other life-extending techniques that are not wanted by the patient, possibly adding to discomfort, pain, and suffering. In other words, decreasing the quality of the patient's life.